I think we're ready to get started, everyone. Good afternoon, everyone, or morning for attendees on the West Coast. Chime is pleased to present the session, Health Policy, Navigating Our Digital Future. I'm Mari Savickas, Chime's Vice President of Public Policy. I am joined today by 4 panelists, Liz Johnson, Karen Wilding, Elisa Silver, and Dr. Andy Gettinger. Thank you for tuning in. Our session goes until 1:55. We have a lot of ground to cover, but if there is time remaining, we will turn to questions in the chat. Should we run out of time, the Chime Public Policy team can be reached at policy@chimecentral.org. I am now going to ask each of our panelists to introduce themselves, and then we will dive right into our discussion. However, one quick note before I hand this over to Liz. Elisa is speaking in an unofficial capacity. She is not speaking on behalf of the Senate Health Committee or her boss, Senator Alexander. Her comments are off the record and are her own. Also, Dr. Gettinger is not able to field any questions regarding the status of a regulation. Let's see, Liz, I'm going to hand this over to you and we'll get started. So go ahead, Liz.
Terrific. Hello, everyone. I'm Liz Johnson. I'm recently retired as the Chief Innovation Officer from Tenet Health and have about 50 years of healthcare experience and really looking forward to talking with you today about policy. Karen?
Thanks, Liz. My name is Karen Wilding. I'm a Senior Director of Quality and Value-Based Care at the University of Maryland Medical System and also serve as a Compliance and Privacy Officer for our clinically integrated network, the Quality Care Network for University of Maryland.
Hi, everyone. I'm Elisa Silver. I serve as the Senior Health and Oversight Counsel on the Senate Health, Education, and Labor and Pensions Committee, or the Health Committee in the Senate. I serve under Chairman Alexander, Senator from Tennessee. And just to reiterate what Mari said, anything I say today is not on behalf of the Chairman, the committee, or the Senate. All opinions are my own. And I'm very happy to be here. Thank you.
Thanks, and good afternoon or good morning, as Mary said. I'm Dr. Andy Gettinger. I'm an anesthesiologist intensivist with 30 years of clinical experience, former CMIO at Dartmouth and Associate Dean for Clinical Informatics, and now I serve as the Chief Clinical Officer at the Office of the National Coordinator for Health IT. Mary, back to you.
Well, as you can see, we have quite the lineup today. So I'm going to begin with Liz. We have a series of questions for our panelists, and we're going to roll through them and have a nice moderated Q&A. So Liz, your policy acumen rivals the best. Advocacy is a high-touch sport. Providers, vendors, and others were preparing for the final rules from the Office of the National Coordinator for Health IT, otherwise known as ONC, and the Centers for Medicare and Medicaid Services, otherwise known as CMS, surrounding the information blocking and consumer access rules to data when COVID hit. How has the age of COVID changed the trajectory of health IT and the digital health priorities?
Well, I would remind everyone of the movie Mission Impossible. That movie theme was no plan, right? No backup and no choice. That's where we were. When the COVID showed up, the pandemic showed up within our environments. We had a digitally charged environment and no plan. Nobody was coming to rescue us, and we needed to move very, very quickly. But this is a great time for us because in a virtual world, we're able to really look at technology, take advantage of innovation, and look at how policy impacts us so that we can move forward for the future. Over the next hour, we'll be talking about a number of things related to policy, and we want you to keep something in mind. You really have the opportunity beyond any other time in our lifetimes to come forward and do several things. First, follow the congressional hearings and understand what's going on in terms of enactment. Understand where resolutions or laws are going to become part of what we need to respond to. So if you do that and you talk with your providers and the patients who consume your apps and so on, you'll be ready to help us move forward. So take advantage, get excited, and we're ready to talk to you about policy. Mari?
Thank you, Liz. So my next question is for Karen. So Karen, you've been a big proponent for data standardization, and you've expressed concerns that this needs to occur across the care continuum. I've also heard you say that most care does not happen inside the 4 walls of the hospital. So why is it so important to work with physician practices, skilled nursing facilities, home health agencies, and others in the post-acute long-term care settings and what needs to occur from a regulatory standpoint to help facilitate meaningful data exchange across the care settings?
Thanks, Mari. Well, I am a firm believer that we have an obligation to care for patients across the continuum. And we really need to take a step back as we're looking at the healthcare delivery system and look at where all of the spend, where all of the care is occurring, and where all of that data is sitting. We know that in a digital era right now, most patients have a Fitbit, they have other healthcare data that's sitting about. We know that most care is occurring outside of the brick and mortar hospital facilities. Now, from a volume standpoint, care is occurring. From a cost standpoint, we know that the vast majority of healthcare costs that are impactable occur in those hospital settings and in those professional services. Mm-hmm. And where we focus most of our health information technology infrastructure has been around the acute space. We have slowly started to hold skilled nursing and long-term post-acute facilities. Ambulatory physician practices were part of the meaningful use scope, but we know that they were a little slower to adopt in some of the hospitals. And so we continue to struggle with data consistency and standardization across the continuum. And so I would urge that as we're evaluating policies and looking at new technologies, that we are looking well beyond just the brick and mortar of our hospitals, but that we're looking across. And what I would just say as a patient and as a caregiver, when we think about our ability to give people high quality care and improve their outcomes, look at the examples that we see around medication errors that occur, patients who leave skilled nursing facilities and long-term care facilities and end up back in hospitals as a result of really unfortunate events related to medication lists, medication reconciliation either not occurring, medication lists not being transcribed correctly, or information exchanged. That's easy. We can fix this. And so when we think about easy areas to improve quality, outcomes, reduce those avoidable utilization, and improve overall well-being for our American citizens, we need to look at things that are as basic as medication lists across the continuum.
Yeah, that is so true, Karen. I mean, we've seen CMS move into this space with some of their, what they like to call like policy levers, but it's so important that we allow innovation to flourish and that providers and vendors and others are part of this conversation. So it doesn't always have to be a mandate, but if the sector isn't moving quick enough, then we're going to have mandates for certain. So let me turn my next question to you, Eliza. Let's talk about, we're going to go back in time for a moment. So high tech, right, was codified as part of the Stimulus Act all the way back in 2008. 8 years later, we have the 21st Century Cures Act in 2016 was signed into law. And now we're, present day, last May, CMS and ONC released their final interoperability rules. That begs the question, what is in store for the future of health IT? Last year, there was chatter around a second CARES package, AKA CARES 2.0. Where do you see this heading, and what do you see as the next major health technology initiative that Congress may choose to focus on?
Sure, thanks, Mari. So as you described, the federal government did spend many years and $34 billion to make sure that our health records were digital. The challenge that we now face is how do we make all that disparate data interoperable? And as you said, that's why in 2016 in the 21st Century Cures Act, we required that all electronic health information become interoperable. That's the access, use, and exchange of health information. And then also we prohibited information blocking, which is behavior that interferes with such access, use, and exchange. There have been a number of years where ONC worked really hard on writing rules to implement those provisions in 21st Century Cures Act, and they were only just finalized in March of this year. And we know a lot has happened. A lot happened in this country and the world in March of this year. So we are really focused on the implementation of those final rules. We know that because of COVID, resources have been stretched really, really thin, and it may take a little bit longer to implement those rules than we had initially anticipated, but we're very eager to see how that goes. We were happy to see that ONC's rules required interoperability through FHIR APIs. We were thrilled to see that ONC fleshed out what information blocking is and isn't, and is continuing to provide clarity on those points. So really, where we're focused is making sure that we that we implement those rules first before we start adding on more and more and more requirements. We would like to see how this works first. With regard to Cures 2.0, I think that was really a House of Representatives exercise where there were a lot of opening listening sessions. And I think that's an exercise that we're always continuing to engage in on the side. So please do come talk to us about what things you would like to see in the future for health IT. Our ears are open, and we're always thinking forward. With regard to what's on the horizon, I think privacy is something to watch. Everyone's minds are on the GDPR, on CCPA, and we know that in the United States, we do not have any one national privacy law. We have sector-specific laws, including HIPAA, which really covers a specific kind of health information called protected health information. There have been a number of bills in this past Congress introduced to address what some perceive as gaps in protection of health information and consumer protections. And that's for that health information that's created through health apps, through wearables, perhaps genetic information, geolocation information, biometrics. So what we can all agree on is that there's no agreement and it's slow moving, which is, you could argue, a good thing because it allows for opportunities for the private sector to come and weigh in. So we invite anyone to come and speak with us and share with us your perspectives on where this direction should go.
That's great, Lisa. Thank you so much. And certainly we'll be watching the privacy conversation very carefully. So let's move on to you, Dr. Gettinger. As you know, one of Chime's long-standing policy priorities has been to advocate for Congress to remove the ban on patient identification. And while this may sound like a very technical and wonky issue, it comes down to patient safety. And you, being the patient safety advocate, had taken a very strong interest in this. So I think most people would agree they don't want to be mistaken for another patient or have their records mixed up with another patient, and that clinicians need their access to the patient's records at the point of care. What can you tell us about this? Can you give us an update on the status of the report that Congress asked ONC to do last year, and why is this such a thorny issue for some?
Thanks. And thank you for identifying this as an issue that I'm personally very passionate about. If we don't identify our patients and then link that identified patient to their electronic health data, the potential for real error and problems, and that's either commission or omission, that things happen because we've merged data, or things don't happen because clinicians don't have the data. And this issue, some of the issues we've been just touching on are current issues, 21st Century Cures Act, information blocking, our current rule. This goes all the way back to 1996 when Senators Kennedy and Kassenbaum introduced and HIPAA was promulgated. And then subsequently a prohibition that was introduced into the appropriations language in 1998, specifying that HHS cannot take any action to implement a national patient identifier. If you step back and you think about it, 1998, what was that like? Most of us were not connected to the internet. Google, Facebook, Amazon really wasn't part of our routine life the way it is today. And yes, I did some Prime shopping yesterday. iPhones didn't exist. That predated, the iPhone by 10 years. So what we're looking at today is a very, very different space. So we were delighted that as part of the negotiation between both sides of the Hill that we were asked to look at this issue again. By the way, we've characterized this not as a national patient identifier, but as a patient safety identifier, again, recognizing the potential real serious consequences. Most folks don't understand how frequently we have errors and what the cost is to the healthcare system. We heard testimony from Intermountain about both specific errors when we did public testimony to facilitate this report back to Congress. We also heard about cost. And we extrapolated the experience at Intermountain, and it resulted, if you apply it nationally, to about $3.6 billion a year. So there's lots of opportunity, both in terms of clinical care and taking cost out of the system to better identify our patients. So where are we in this report? We've had, as Congress asked us to do, we've touched base with stakeholders. We've had 2 very public sessions quietly behind closed doors. We also have tried to coordinate. We are the Office of the National Coordinator across the federal sector to find out how important this is to some of our federal partners and even some partners that you may not imagine. So it's obvious that the Department of Defense provides health care, the VA provides health care. It's less obvious that Customs and Border Patrol and the Bureau of Prisons provide health care and have similar kinds of challenges and issues. We also heard testimony from the FBI that how are we going to handle the 500,000 to 1 million individuals in the United States who currently try and conceal their identity because there are wants and warrants for them, and yet they receive health care. You know, at the outset, we didn't think about that, but we're thinking about that now. So we've engaged 3 national experts from different areas to work with us. We received written testimony. Chime was very delightful in sharing their opinions. We thank Chime publicly and all the other folks who contributed content, and we are working to create that response back to Congress that we are pretty excited about. You can't have an interoperable system if you don't have patient identity and then reliable linking. Back to you.
Well, thank you, Dr. Gettinger. I mean, that is exactly right. I love that you call it the patient safety identifier. And, you know, thank you for being the champion and for carrying the torch on this really important issue. And we're going to continue to educate folks about this issue that, I mean, we may not all agree on what the solution is, but I think we all can agree is we're all patients and we all want safe care. So continuing on this thread, let me go back to you, Liz. So let's just stay on the topic of patient ID for a moment. Let's get into this a little bit more. So many organizations have recognized that the inability to accurately identify a patient and correctly match them to their records is not only a safety issue, but as Dr. Gettinger noted, it's also an interoperability barrier. And so now that we have, you know, we're in the era of COVID-19, like it or not, and the vaccine administration is hopefully, you know, close to being around the corner, there are subtle questions about how a 2-part vaccine will be administered correctly given the challenges we have with patient identity. So could you give us your thoughts on how you anticipate this will work with so many challenges around patient identity and record matching, and how has the need to track patients through the COVID vaccination process accelerated the need to accurately identify and match patients? And finally, is there a way for, you know, a pathway forward for innovation?
Right. I think, you know, it's an interesting question. I would be far-reaching if I were to say I had it all figured out, because I don't. But what I do know is that we have a number of areas related to COVID that we're not doing as well as we should be. Andy mentioned how many people don't even want you to know their identity, and yet we're testing on a daily basis, trying to determine where people are either positive or negative, eventually whether they have antibodies or not, and whether that's significant or not. And I think this is really going to come to play in a very, very significant way when we get to vaccines. So let's talk about vaccines, not about who took their vaccine off the market yesterday or is asking for further testing. It's coming regardless of the timing, right? Mm-hmm. So let's pretend today that we have a vaccine and that it's a 2-dose vaccine. So that for every time that one of us goes in, and I'm in that, you know, over 60, way over 60, age group, and looking forward to getting a vaccine. However, I want it tested adequately, and I clearly understand that I'm going to have 2 doses. Those doses will probably be between 21 and 28 days apart. So I go in and I see Andy, Dr. Gettinger, and I say, hey, how about a vaccine? And he says, sure, I've got the Merck vaccine right here. And he gives me the vaccine, and we sign off on all of the identity and so on. But the next week I'm back in Texas, and I don't want to fly to see Andy. I want my own doctor to give me the vaccine. How is he going to get that information? How is he going to track it? How is he going to be sure that he's using and pay attention to this, the same manufacturer, because the way the vaccines are being built is the same manufacturer must give you dose 1 and dose 2. And it's critical that we understand that. Another place that the information needs to be gathered, and we've all talked about interoperability, is what if I have an adverse event? You need to know that right away so that either we change manufacturers, we come up with a plan to vaccinate me appropriately. And this is going to happen millions of times over and over across states, across providers, and we're really struggling with how do we register you? They want us to be able to report within 24 hours that you've received a vaccine. Let me just mention for the fun of it that the vaccine has to be stored at sub-zero temperatures. So there's that little issue that goes along with all of this. So you have an incredible opportunity. We're going to have vaccines, single manufacturer, 2 doses, have to be able to identify us. We have no national identifier. Is my hair falling out yet? Okay, just checking. I want to look like Andy, right? No. So I know it's a huge issue for us.
Well, okay. So Nurse Johnson, let me ask you another question. So part of the reason that we actually wanted to have this panel was to actually put out a call to action. And so we can do that, right? I mean, you've been the massive proponent as part of the Time Public Policy team, and you've been in Washington many times, but not everybody's a Washington insider. And so what can we do to help educate the audience about what can be done on this issue? What can they do today?
Great question. And I want to also go to diversity, but let's answer that question first. There's a coalition out there called Patient ID Now. It's free to join. We'll provide the connection for you. Get involved. Find out what's going on and get involved. And we're very fortunate to have Alicia with us. And call your senators. Tell them what you're worried about. Reach out and be a part of the solution. We are putting out a problem that takes innovation to solve. And I want to go further than that to tell you the disparity issues also come into play with the vaccines. When you talk about patient misidentification, the Black population is only 13% of our patient population. However, 21% of the time, a mismatch of that population occurs. Hispanics are only 21, but make up 35% of the duplications. I'm trying to get all the numbers right. So it's really important. We've got a migrant population. Andy mentioned a population that doesn't want to be identified, but probably wants a vaccine. So it's huge. Get involved with Patient ID Now, and you'll have an opportunity to really have a voice. Call your senators. I often say when I teach advocacy, if you don't know who your local senator is, if you don't know who your state representative is, shame on you, because those people really do listen. Andy and Alicia can both tell you, we do spend time in Washington. They're very receptive to our ideas, and they pay attention and come back with solutions. So take the opportunity.
Well, thank you so much. I mean, Liz, that's exactly right. I mean, the House has actually acted twice. They voted to remove the ban, but we're still working on the Senate. So your point about calling your senators is really timely. So thank you so much, Liz. Well, while we're on the talking of the Hill, let's move back over to you, Lisa. So let's move on to another topic. So one of the biggest healthcare issues surrounding the pandemic so far, and we really can't not talk about telehealth and connected care. So there's been an appetite to do something in Congress on telehealth. I think there's been I think I've lost track of how many bills are about 100. And it's evident by this, enormous number of bills, like dozens and dozens, and many hearings that we've seen on this issue. So most of the telehealth policies that have been allowed during the pandemic, however, are permitted under waiver authorities. And those are allowed to continue only so long as there's a waiver, but we really need Congress to act. So that's really what needs to occur here. So what's the status of telehealth in Congress, and what is the prognosis for getting something meaningful across the finish line before the end of the year? No pressure.
Thank you so much, Mari, and thank you for not asking me about the patient identifier. But please do come talk to us if you'd like to talk about that. So with regard to telehealth, you're right. Since the public health emergency was declared, the Department of Health and Human Services implemented over 30 waivers on restrictions for telehealth access. It's been quite an incredible test case for us to watch and see what's happened and realize the true potential of telehealth for quality, access, and cost. Seeing that momentum, we've heard from in New York, the telehealth or virtual utilization of health services increased by thousands of percent. I mean, that's incredible. 1% to thousands of percent increase. So really tremendous. We capitalized on that momentum in the CARES Act by funding some expansion for the use of telehealth, including expanding rural broadband so we could help folks in all communities access telehealth services. As you mentioned, the Health Committee did have a hearing on telehealth during the pandemic and beyond. We've actually had many, many hearings since the pandemic started, but they've all been with senior government officials. This was our one non-government official hearing, which shows how important this was and is to the Senate and to the chairman. So during that hearing, we heard from academics, from healthcare providers, and from a payer. We learned that telehealth truly can increase access, increase quality, and decrease cost. So as you mentioned, there are a number of bills in the House and Senate to see how we can keep this, as I said, momentum going. I will have to plug the Telehealth Modernization Act, sponsored by Chairman Alexander and our team. What we did when we drafted this bill was look at some of the broadest consensus pieces and some of the biggest barriers to access of telehealth services. The biggest one in the bill being abolishing, getting rid of restrictions on originating and geographic sites. So meaning that any patient can access telehealth wherever they live across the country, including in rural areas, from their home. That's a big deal. Other provisions would give the Secretary the authority to expand the list of telehealth providers, to expand the list of services that can be provided over telehealth, and many other things. So with regard to whether this can get passed, anyone's guess is as good as mine at this time. We were hoping to attach some sort of telehealth bill to the next COVID relief package. One day we're preparing for its passage. The next day we learn that from a tweet that it may not be happening, and then that changes. So as every day progresses, it's looking less likely that a COVID relief package will get passed by the election. But then there's always a chance it could pass after the election. There's a chance we could attach something to continuing resolution to fund the government, which we need to pass in December. We also have the National Defense Authorization Act that we also have to pass before the end of the Congress. So we're never giving up. There are opportunities, but please come talk to us about what you'd like to see in telehealth package. Thank you.
Yeah, thank you so much. It's been such a wild ride with this, and we're so appreciative for your committee and the administration's leadership on telehealth and really prioritizing this. One thing we like to note is that, providers didn't even need to be told to do this. There was no mandate. They just went out and did telehealth, and look at that. They can innovate and use technology without a regulatory hammer. So that was so nice to see, and we too have seen the thousands of a percent uptick. So completely agree with all those points. Let's go back to you, Andy. I mean, I know we could sit here and discuss the merits of telehealth all day, and I'm sure I'd love to do that, but we only have about 25 minutes left. So let's just talk a little bit about telehealth through the lens of quality. I mean, there's a lot of still questions about, it's going to be expensive to pass a big package, and you got to look at what quality outcomes. This administration's been very, very supportive of telehealth. They just put out some more policies yesterday about coverage for Medicare over telehealth, and they've also been focused on reducing the burdens on clinicians, which has been a big priority of yours. So one of the big concerns related to telehealth is whether patients can get the same level of care through telemedicine as they do in person, and what kind of great use telehealth has been on the clinicians in terms of has it reduced their, their burden. So putting on your dual hat as both a clinician and a patient, how do you see quality being impacted by telehealth across the care continuum? Do you see this as a solution to some of what ails our system around clinician burden? And finally, how much do you think this will affect whether we see lasting changes in telehealth policy?
Wow, a series of really great questions, and I am delighted to take them. So first of all, I see that telehealth, just like identity, has exacerbated some of the challenges and problems that people experienced. So $200 million, it was a great investment that the FCC is managing to try and improve rural connectivity. That persists though, and some of the estimates are that far more resources will be necessary to achieve that. Think about FDR and the Rural Electrification Program as a parallel, because you really can't do much of what happens in modern day life without really decent broadband internet connection, whether it's homeschooling, telehealth, or, as I've already mentioned once in this conversation, online shopping. So let's talk about quality. There are clinical encounters that probably are not just equivalent to an inpatient setting in a doctor's office or a nurse practitioner's setting. They're probably even better if done through telehealth. So think about pediatricians who have a window into seeing the home environment where the kids are being raised and what it looks like. Think about encounters that have a little bit of what I'm going to characterize as a stigma attached to them. Mental health, seeing a psychiatrist or a psychologist or a social worker, that angst about sitting in the waiting room and seeing that neighbor from across the street who knows that you have needs in that space. Those are really important examples of where telehealth may be better. And I am so proud of the clinical community who is frequently described as stuck in their old ways, who segued very, very quickly into this space and adopted it. But going back to my first point, there are those that have and those that don't. So if you're a small independent practice, a federally qualified health center, for example, or an independent practice, you don't have the ability to have IT support. Your IT support is either the clinician or the office manager, and sort of making this transition is much harder than if you're part of a system and you have folks like Liz in her former role who can come in and say, here's the IT solution for you. And oh, by the way, your clinical care is going to be linked to your administrative care so that you can not only document, you can actually get a bill out, which is important. And so there are ongoing opportunities, challenges there, but just as the entire ecosystem made this huge transition, we've now seen it drop back a little bit. I suspect it'll tick back up as concerns about COVID are ticking back up across the country. And what's the right level? I think it's going to be, it remains to be seen. We took public testimony at our HITAC, our Federal Advisory Committee, from Michigan. And their observation in terms of telehealth is that not all disciplines were able to adopt it as quickly as other disciplines. Working with HRSA, we heard ONC is, again, trying to support the notion of telehealth. And HRSA has two centers of excellence, the University of Mississippi and the Medical University of South Carolina. What's interesting is they experienced very similar observations, but guess what? The disciplines that were successful in Michigan were not the same as the disciplines that were successful in Mississippi or MUSC. So there's a lot of opportunity for us to learn more about what works and what doesn't work and how to facilitate and make that better. Back to you.
Yeah, Dr. Gettinger, you raised so many good points here. I mean, there's the broadband issue, there's more data. I mean, we're mixing all these issues we've talked about today with all the telehealth that's happening, more data's flying around. So let's pick up on that one little piece and move over to Karen. So Karen, there's been a big push recently for leveraging not only clinical data, but also administrative and claims data, which often gets overlooked. And here we are, with every passing day, we're creating more and more gigabytes, I don't know, lots of data is flying around. So with all the federal efforts to standardize data, clinical data is still messy though. So can you give us your thoughts on why it's so important not to overlook the value of claims data and what can be done to better leverage it to improve care and outcomes, and can FHIR help?
Sure. Well, so let's think about where we as consumers go. As patients, not all of us have a brand loyalty to a specific healthcare system or specific EMR, right? So we go to get care where we either have trust and faith in the provider, which may or may not be affiliated with a specific organization. We go to the urgent care down the street because it's convenient and it provides good access. And so when you pull together a healthcare delivery system where we don't have information that's all pulled together clinically or from a claims standpoint, you automatically are presented with the challenges that we have today. The difference with claims data is that Karen, who happens to have Blue Cross Blue Shield insurance, if I leverage my insurance at all of those locations, I see a cardiologist at one healthcare system, I have an emergency department visit as another, I go to the lab down the street or the urgent care, those claims data, you do have the ability to pull that information together. So you start to get a more accurate picture of the care that is being provided to me around the services and the utilization that is occurring. And that's powerful. That's incredibly helpful to the care team to better understand what care has been provided to patients. The other value of administrative and claims data that we often overlook is around screenings. So when we think about gaps in care and our ability to really try and help address population health issues, how we have an incredible opportunity ahead of us is to look at people's prior claims utilization. So patients who have had colonoscopies or mammograms or other cancer screenings, people have changed their jobs, so their insurance changes. People, especially right now in a COVID period, we have an incredible amount of people who are now unemployed, who have had their insurance change or they're leveraging COBRA. And so what kind of impact will that have on care delivery as a result of COVID-19 unemployment? We don't know yet. We don't know yet. So it really begs the question of, as a clinical provider, the importance and value of not just the information that I have within my EMR or within other organizations that have a similar EMR. It's how do I have information that shows the full picture of the care that has been provided to a patient, and that includes the financial and claims-related data. As it pertains to FHIR, I'm not sure. I hope so. I think that FHIR is an incredible tool that we can be leveraging more and more. I think that there's still a slow adoption rate around FHIR, simply because people don't have a good understanding of all that it can do. When we think about where we were historically with other adoptions of standardized technology, look at how long it took for HL7 to be adopted and implemented and part of the standard protocols. And we fast forward and look at direct and CCDAs. And even now, that was almost 10 years ago, and we are still just getting momentum in place. I think that the larger organizations have been able to resolve and remediate and put those standards in place. There are plenty of portions of the healthcare delivery systems that do not have direct and CCDAs up and running like they should. And so FHIR, I think, is just another version, another opportunity for us, no different than HL7 or direct, and now there's FHIR.
Well, you certainly, I mean, there's so many pieces there. You certainly know that Congress knows what they're doing when they put API in the statute. So, and we have ONC to thank for naming FHIR release version 4. So thank you, thank you, thank you. Clearly, COVID has slowed us down a little bit, but we're still tracking ahead here. We're, maybe a little bit longer, and hopefully we'll have a little bit more time as, one of the ONC rules is we're waiting for that to drop, but we're moving in the right direction. One of the things I want to go back to is privacy. And so, the APIs, the connecting to third-party apps, it's raised a number of important issues. And, certainly, it's not as if APIs are going to disappear. They're here to stay in healthcare. They got here late, but they're here to stay. So there are some unsettled issues around them with respect to privacy. And so, I know we're waiting for the HIPAA rule to come out, and that will obviously we'll be taking a close look at that. But there's many companies who are not on the panel, like, Liz and Karen, you guys sit in the provider seat, who are not covered by HIPAA. So let's get into that. I'm going to go back to you, Liz, and then after that, Andy. Let's just talk about Elisa's comments. She made comments about privacy, and Congress is definitely looking at this. They were, I think, slowed down by COVID this year like everyone else, but what would be your recommendation to companies who are not required to comply with HIPAA, Liz, when it comes to handling consumers' health information? And how do they preserve the spirit of innovation while also maintaining the trust of the consumer?
As Andy said, there's always lots of questions in every question, right? So first of all, raise your smartphones and do the prayer. You're all doing the prayer now, right? We're looking at our apps. We're paying attention to what data is out there. Oh, good, I'm a diabetic and my blood sugar is under control. That's the world that we're in today. It's exploding, and it's an incredible way for patients and providers to get data. So we're all for it. You guys that are out there doing the innovation piece, just like I did, you know how critical it is to get that information in two places. One, I have a chronic disease, I'm a diabetic. Or two, I have an acute problem and I need to be able to find my meds and be able to tell someone what's going on with me. I take chemotherapy. What kind of chemotherapy do I take? How does it work? And so on. So it's an incredible time for us. But we have a couple of issues that I want to talk about, and I know others on the panel want to join. The first one is what I call Terms and Conditions 101, except it's not 101. Everyone's not quite as versed as some of the people on this panel, and being an attorney or otherwise. And so I don't know about you, but I know what I do with terms and conditions. I say, I agree. Now, I've just signed up for 13 pages of details I have not read. I'm being honest here. So I may have given you permission to use my data in all kinds of ways, whether it be marketing, whether it be for research, whether it's some things I truly agree with, some things I don't, but it's too hard to read. So we need your help. We need terms and conditions that are easy to understand and transparent related to how the data is going to be used. We need to be able to opt out if we don't want our data used for a certain thing, but want it for another. I had a genotype done of my tumor. I am absolutely in favor of someone taking that data, looking at the response I got from the drugs I've been given, and using it for another patient. 100%. Don't care if my name's attached or not. But like Andy said earlier, maybe I'm seeing a psychiatrist and I don't want that data out there. So how do I do that? How do I understand those terms and conditions and make them simpler? The second thing that Mari alluded to is that third-party apps are not subject to HIPAA. We all know that, so we know that it's critical that we pay attention and you guys and ladies produce apps that are safe. So the data leaves one of our provider organizations or leaves me as a patient and goes someplace else. The way the terms and conditions are built, which is the way it should be, is I now as a patient am responsible for that data, but I don't understand privacy and security, and I don't know how to make it safe. So we want you to help us by producing software, you know, whether they're on an iPhone or on your PC or wherever, that is safe, that is encrypted, that is following the rules, that does have strong passwords. So I think that somehow we have to find the balance. This is where we want to be. We want to share data. We need data to give good care. We need data to get good care. So help us by ensuring that terms and conditions are understandable, and that by being a third-party administrator, don't worry about not being, subject to HIPAA today. Follow the same rules we do, and it'll be a better, safer world for interoperability. That's my speech for the day.
Thank you, Liz. So, Dr. Gettinger, you're sitting in the regulatory driver's seat here. Arguably, ONC doesn't necessarily have jurisdiction over this area, but is there anything you want to add to that as someone who is on the administration side as you're looking at this very, I know you've been collectively tracking these issues around privacy, and you work with the federal, Trade Commission and also the Office for Civil Rights. Anything you want to add?
Well, it's clearly challenging space from a regulatory point of view. There isn't clear authority delegated to the executive branch to step into this space and regulate it. I want to acknowledge what Liz said and think that is very important. This transparency and what happens with your data when you voluntarily commit it to an app or another setting is important to an individual. Now, the reality is we know that there's a spectrum of response from folks in the United States. Some don't care at all. They believe there's no such thing as privacy, that all this information's already out there everywhere. And if you look behind the scenes, and I'm going to pay very close attention to some of the hearings coming up on the Hill, there are large organizations that know more about my healthcare than my actual healthcare providers know. So, so there is that segment of the population that says it's already done. We don't know what you're worried about. Then there's a segment of the population that is so concerned about privacy that they actually don't even share information that's key and critical for their well-being with their own treating clinicians. And I'm not sure that that is any more successful as a strategy than the other end of the spectrum. And then there's what I believe a substantial part of us, and I'm going to put myself in that category, in the middle. So rare to be in the middle these days, just to say, where I care about what happens to my information. I want to know where it's going. I, like Liz, would share information for positive things. And oh, by the way, if I have an opportunity to know about that, I'd like to weigh in one way or the other and not be told that this is what is going to happen. And all of those comments were as an individual, not as a regulator. I just want to reiterate that. Should anybody be paying any attention? Thanks.
Well, thanks very much, Dr. Gettinger. I mean, as I said earlier, we're going to be keeping our eye on this, and still sounds like every patient has to be their own advocate for the time being until we sort through some of the privacy challenges. So let's go back to you, Lisa. We're getting towards the end of our time here. We can't not talk about COVID, so let's just talk about COVID for a moment. So while a vaccine appears to be on the horizon, hopefully more sooner than later, you know, from all indications, it still seems like we're a ways off from our, you know, pre-COVID fancy-free days before back in March. It seems like an eternity ago. Some of the infrastructure has been built, you know, to communicate data exchange, thanks to investments by Congress for data reporting for public health reasons. So some of this stems from high tech and the cures, and more recently in the stimulus package. But our data collection and reporting capabilities are they're struggling. So while we continue to improve how we exchange data, especially during this really difficult time, what do we need to do to modernize the data we have and the infrastructure we have?
Thank you for that question, Mari. Yes, you're absolutely right. We hear stories all the time of public health departments printing out Excel spreadsheets and faxing them to other health departments or to the CDC, or texting, or writing on Post-it notes, tallying reports. This is not an effective way, as I'm sure we can all agree, to report in public health issues or conditions. You know, you can have a lag in reporting. We see a lot of inconsistent data elements being reported. People confuse, what does it mean? How, what, where, when? And then also a lot of these reporting methods are not very secure. So we really do need to tackle this problem. This is something that Chime and others have brought to our attention for many years now. Last year in 2019, we passed out of the Senate Health Committee the Lower Healthcare Costs Act that included a provision for public health data modernization to do just this, to fund and facilitate the modernization of public health surveillance and reporting at the federal, state, local, territorial, and tribal levels. Every level needs it bidirectionally. We need to involve all actors, labs, hospitals, payers, patients, providers, everybody. This will help us not only respond in an emergency situation, but be able to understand health trends, predict health trends, and then respond much more rapidly and in a more fulsome way. When it comes to what Liz was describing earlier with regard to second doses of a vaccine, this is certainly a concern of ours, and there have been bills floating around. I don't know if they're all introduced yet, but there's been a lot of conversation about how do we make sure that we're ready right now for the vaccine. And that's something that we're thinking about very closely, and welcome comments and thoughts from audience and others. But also long term. Chairman Alexander has said many times that in our globalized world, as Jared Diamond describes in Guns, Germs, and Steel, we have the airplane these days. So the airplane and our modern world will only continue to give us more pandemics, unfortunately. So how do we prepare for the next one? And that's really going to rely heavily on public health data modernization. So in the CARES Act in March, we appropriated billions of dollars to the CDC for activities that include public health data modernization and surveillance at the federal level and all other levels that I mentioned. We're watching that closely and hoping that we're able to improve our reporting in the near term and in the long term. And while the Lower Healthcare Costs Act hasn't yet come to the Senate floor, we haven't given up, and we're going to continue to try and push that so that we can get a much more sustainable long-term funding stream and better technology, perhaps even look at standards for interoperable reporting systems. Thank you.
Thank you, Lisa. We have 2 minutes left, so we're going to go to the lightning round question, and then we're going to wrap it up. So I'm going to go over to you, Karen, and then you, Liz, to just maybe give the audience some pointers. Again, back to the call to action. How do you engage your policymakers, your lawmakers? So, Karen, you first. Which issue would be most impactful for attendees to advocate for with their congressional representatives or with the administration to improve patient outcomes? Your thoughts, Karen?
Yeah, again, advocating for transparency across all aspects of care, making sure that they're looking not just at hospitals, but that they're looking at all areas where we deliver care. It could be at the Walmart down the street, it could be at the CVS pharmacy, it could be your hospital or your doctor's office. We need to have data that's shared across the spectrum.
Okay, you, Liz?
I would say we need, as Andy calls it, a patient safety identifier. We need a way of making sure that the data that we're sharing belongs to you so we can give you the very best care that's available.
Well, I've got 1 minute remaining, so rather than launching into one more question, I'm just going to move to wrap up. We're really close to time. If anybody has any questions, we can, again, and maybe Cassie and Andrew can put it in. We're at policy@chimecentral.org. We can answer your questions, whether you're a member or not, so please contact and reach out to us. I also want to note that we have our virtual fall forum is coming up, CHIME 2020 on November 10th. We hope to see you there. And again, the last thing I'd mention again is the Patient ID website, patientidnow.org. So I want to thank our panelists for this really engaging conversation. Thank you for joining us today. We appreciate Health inviting us in and having this important policy session. So thank you very much, everyone. And we'll talk to you again soon.
Thank you, Mari.
Thank you for having us.
Thank you.
Yeah, thank you.